I think we're stepping into a completely new landscape, and we don't know where the rivers and mountains are, so we're exploring it.
But to Jessica's point, it is like a broad new frontier, but the way that a lot of people are approaching it right now is kind of like the Donner Party. You're a lot of times being sold a map, and you just kind of trust that the map is correct, and you may end up being stuck in the Sierras and having all sorts of horrible things happen to you in a horrible winter.
And just remember, our workforce, they're not all cliff jumpers. So maybe John and Jessica and I, maybe we don't mind, having a parachute and jumping out of the plane and trying scary new stuff. But many of the people in hospitals are librarians, they're chefs, they're service oriented, they're careful and cautious. So I think everybody should be using artificial intelligence. Don't be afraid to use it, try it, and put in that AI governance. You're totally capable. You're a change agent. Go use it today.
Welcome to Beyond the Blueprint. My name is Greg Malkery from Spyglass Consulting, and I'll be hosting today's panel discussion on AI governance in healthcare. This episode is part of our collaboration with AMDIS, the Association of Medical Directors of Information Systems. To help us explore these issues, I've invited three amazing health IT leaders who are on the front lines of bringing AI into clinical practice. We have Dr. Amy Sitapati, Chief Medical Informatics Officer at UC San Diego Medical Center. Dr. Jessica Schlicher, Chief Medical Officer for Virtual Care at Providence Health. And we have Dr. John Lee, President of HIT Peak Advisors and former CMIO at Allegheny Health. Join us as we explore the new world of AI in healthcare, learn about opportunities and challenges for using AI, and find out how healthcare leaders can navigate this landscape when we go beyond the blueprint. A 2023 class survey found that more than half of hospitals are using AI, but less than 20% have any formal rules or oversight in place. During today's panel discussion, we're going to explore, are hospitals ready for AI, or are they risking harm with premature adoption? Who really owns AI accountability within complex health systems? And how do we avoid clinician burnout while driving AI adoption? With that, why don't we get started? Amy, I'm going to start you off. Putting aside the hype on what's AI useful for within hospitals today, whether it's about patient care or day-to-day operations.
Yeah, we absolutely love Health AI at UC San Diego. It facilitates access. So we have more than 80 patients waiting in our emergency room for beds, and how to predict the next 3 days volumes are really critical. So we have AI and machine learning models to help us do that. The second thing is documentation. And so using ambient to help us really better document our notes. And like many across the country, we're seeing improvements in certain specific areas. I myself used it and saved 4 hours the first day and fell off my chair. It was the most revolutionary thing I'd seen. And then the third thing is really safety. All of us know that harm happens in hospitals every day. Having AI in the loop means a machine learning model can help us find sicker patients faster. And our sepsis model has reduced the sepsis mortality in our hospitals. And this is amazing.
Right. Hey, thank you, Amy. Jessica and John, what stands out to you? Where do you see AI working well within your organizations or the organizations that you represent?
So I would say that it's been a bit spotty. We have the sepsis model in place, but actually one of the interesting things that has happened is that the predictive model has become less relevant, because there's been a bit of a Hawthorne effect with that, in that oftentimes I'm actually initiating a lot of the sepsis workflows before the model actually triggers, because it has trained me to actually think about it. So that is kind of an unexpected but in retrospect, very predictable consequence of that. I think, and I've also started using some of the ambient tools, been really helpful with that as well. I do think that there's just a ton of other potential, because really, essentially, medicine is no longer a biologic science. It's more of an information and data science, being able to try to parse out all the things that are flooding us and trying to make a decision as to what pieces of data and information are important to us. And we have to try to figure out how to do that better.
Thank you, John. Jessica, we're fortunate to have you on our podcast several months ago about all the great work that Providence Health and the Innovation Center is doing. What's going on in terms of what's working at Providence Health now?
So I can't take credit for this, but some of my colleagues have created a GPT that's purely internal to Providence. So that's very cool. So it's compliant with all of our, guarded in terms of our HIPAA and all the other things that can put us at risk. So that's really important. Another thing I'm really excited about, one of my colleagues, Dr. Chris Dale, has started a study for CLABSI prediction. So across all of Providence, trying to predict which critically ill patient is going to have a hospital-acquired infection. We're really excited about that as well. So there's a lot of work occurring that is not obviously all me, right? Or even part me, but very excited about that. Across, in my particular area in Providence Acute Care, we serve, we have about 130 physicians across 8 states and in some enterprise service lines. And those docs are excited about getting started on ambient documentation because we're going to see a very significant improvement in the documentation of our care if there's a timestamp with an ambient note for every single time we touch a patient. So we're really excited about that. I think as in any service business, the people make the business. So the people and the nurses and the physicians and the administrators that create the patient care, the most important thing we can do is ease the burden on them so that they can get back to doing what their purpose in life is, which is caring for folks. And if we can take off that documentation burden and make it so that they actually finish working and can have their life with their families, I think that's going to be the most important result because then their minds can really be focused at work on the best possible clinical care. I mean, there's a lot we're doing, but I think the ambient documentation is going to be it continues to be a real game changer. But on my side, it's the acute care ambient documentation that's really going to help.
Something you brought up last time, Jessica, I'm sorry, go ahead, John.
Yeah, so I do want to touch on what she just said about the people and how I don't think people understand how much time we spend chasing down data, information, and using our brain to collect all of that data and information and abstract and synthesize all of that stuff so that it can be used by other people or within our documentation or make decisions. And that consumes so much of our time just because the information and data are so scattered. That's where these tools are going to come into play.
Thank you, John.
Forgot, Greg, can I tell you one other thing I'm excited about?
You can tell me anything you want.
The other thing is we run a clinical decision platform called MedPearl at Providence. And to John's point, our specialists and many, many specialties have defined, here are all the data points I want to be served up on a platter when I see a patient. So for a neurologist, there's about 60 data points that they normally kind of have to honey badger dig their way through the chart to find. But with MedPearl, all of those things are pulled from the chart. So the very first time that was used, the neurologist who himself designed this tool saw a patient in the hospital and found a lab that had been missed that made a definitive diagnosis for this patient who completely changed the trajectory of her clinical care. So when we put the people doing the work in the driver's seat of the AI, that's when really cool things happen.
I'm really glad you brought that up, Jessica, because I had a great talk with Amy a couple weeks back. We were talking about the use of open evidence in actual clinical practices. Maybe you guys can contrast, what's working as you look at open evidence and what is special about MedPearl? Obviously, I'm not clinical, but would love to see if we can get a better idea to Amy of what you guys have done. And is it something that's really significant? And how does that contrast with the experiences that Amy's team has had at UCSD?
Yeah, I mean, I'll kick us off. So maybe first of all, I think it's amazing, these tools that are coming on the market to help our teams, such as open evidence. This means kind of being able to have an encyclopedia that's sort of AI driven. How cool for medicine. But that being said, some caution just on how to use it. How is it double checking itself? I was in a national forum in the last couple of weeks, and I was talking to people about what open evidence is and how it retrieves information. And they said, well, isn't it sort of like Google, right? It just like pulls it up and then you just copy paste and, you got what you had. And I said, well, that's not exactly how this generative AI tool worked to retrieve your data. Let's talk a little bit. So I said, let me give you an example. If I have a patient, they're immune deficient and they showed up with sepsis in the emergency room, what antibiotic should I use? So I asked the tool, hey, give me the information back. And when I put in the query, it returned to me a lovely description, a page long and multiple references. And I thought, wow, this looks great. I guess I have my antibiotic. And then I looked at the references. It was all wrong. It said, absolutely do not use the antibiotic in this circumstance. So, it did a good job retrieving a credible source, but it actually gave me the wrong answer. So just being like careful and sensitive, it's really good at information retrieval. It can pull a very nice summary. And I think that's the promise. It'll get better and better. You can still use that source, but then you got to actually get into the source and double check the work to make sure you're getting the right answer.
Jessica,
It's
the
kind of
head
like,
chief of content at MedPro, what say ye?
well, in residency, they said, don't be DNR. You guys remember this? Don't be DNR. And that meant a person who did not read. So I would say for appropriate AI interrogation, don't be a DNR. So Amy's point, you have to go to the primary source and read it. And I don't think there'll really ever be a time where you don't have to do that. That's just my prediction, because the standard of care is 6 Sigma, right? Or more. So we don't have the luxury of saying, yeah, ish. So you have to, but the cool thing about open evidence I have found that's really cool is that the links that it gives you generally work, as opposed to some other tools where they'll give you a link and the link is like not related to what you thought it was, or it'll reference it and that's not what it says at all. So I think it's always going to be important to appropriately AI interrogate. This is really fun, you guys. The cool thing, so in MedPearl, there's humans actually vet every algorithm that we have, create and algorithmatize the medical knowledge. Because as you know, from messing around with every tool I get my hands on, they don't think, right? So they can't say like, here's the decision tree, and if this, then that. They're not that good yet. They can give you resources in order for you to put it together in a way that makes sense. But I think if we could put a good tool in the hands of the people doing the work with a little bit of education around Amy's exact point, they're going to create things far beyond what I could even imagine. It's going to be great.
Awesome. Jessica, thank you. But let's move on to the next topic. Lots of really exciting things for us to discuss. And Jessica, this actually is directed to you. Let's talk about the gap between big AI ambition and real AI readiness. Are we pushing AI too fast, or are we not preparing enough?
I don't think it's either of those. I think we're stepping into a completely new landscape, and we don't know where the rivers and mountains are, so we're exploring it. I mean, I teach it in a clinical residency for family medicine docs, and let me tell you that all of the governance in the world doesn't stop them from going on their phone and using tools that they understand better than I do. So I think the change is coming, and we're going to have to work on some basic guardrails and education around it, but I don't think we're going to be able to stop the wave, which is pretty exciting if you think about it. I mean, as long as you read the source for where it came from, great. And I also think for non-clinical things, the AI is so much better than the way we normally do work. For example, I had a medical director come to me, and he runs our EEG program across 7 states. And he said, Dr. Schlicher, hey, I don't want doctors to be woken up in the middle of the night for non-urgent EEGs, like ones that don't need to be read till the next day anyway. Can we get that done operationally? Like, can we make that change? And he was not familiar with like SBAR or, the way you get support from a team and get everybody on the same page for what you're proposing. So we use Perplexity for this, but you could use any different one, and described, you are a physician, this is your specific problem, you don't want physicians to be woken up for non-urgent EEGs. And within about 30 seconds, he had an SBAR, which he edited, sent it to our executive team, and within 10 minutes, he had support of the entire executive team to make this change, which has now improved the quality of life for all of his physicians.
Amy and John,
for leaders, it's important, yeah.
I want to give Amy and John a chance to chime in. Is AI ambition driving the right conversation? Or are we setting people up for failure?
From my perspective, the simple answer is no, not yet. There's a lot of nuance behind that, but to Jessica's point, it is like a broad new frontier, but the way that a lot of people are approaching it right now is kind of like the Donner Party. You're a lot of times being sold a map, and you just kind of trust that the map is correct, and you may end up being stuck in the Sierras and having all sorts of horrible things happen to you in a horrible winter. So, and a lot of people are trying to forge forward without a good map to guide them. And I think we're going to touch on that on the next subject that we discuss. But one of the other things that Amy touched on was, or Jessica touched on, was how she used Perplexity to create that S-bar. And I think, and actually Amy's point about open evidence also touches on this, because there's a huge body of data that's available that can help us, but we have to learn how to guide it better. And the tools that we need to start using is ways to actually make that prompt, make that guidance better to the artificial intelligence tool. So for instance, in the example that Amy brought up on that septic patient, it would be nice to be able to say, okay, this is the query that we want in open evidence, but we also want to insert some of the clinical features of this particular patient. And maybe, I haven't tried this yet in open evidence, but maybe we need to be able to put in some longer form prompts to come up with more precise guidance. And I personally love using open evidence because I'm an ED doc, and I simply just do not have the attention span to read multiple paragraphs in an up-to-date search.
All right, let's give Amy a chance to chime in here. What do you think, Amy?
Well, I want to talk about this all about the people. And, in hospitals, the workforce is like so expensive. And so the people, it's about more than the doctors, more than the nurses. There's so many people with administrative tasks. And when we're talking about AI, it's the whole bundle. It's your rev cycle, having prompts to sort of streamline and find that code in a better way to help the hospital. It's also the executive suite. For instance, I was in the executive suite a couple of weeks ago, and I was walking by, said, y'all have this really great AI tool. Like, are you using it? And they were like, what are you talking about? They said, well, you know how to make an agent? They said, what is that? I said, okay, let's open it up. We get the platform. Tell me what your task is today. They said, well, I got to make this letter. I got to put this business document together. Well, let's program an agent for all of those use cases. Come on, we can do it together right here. And just remember, our workforce, they're not all cliff jumpers. So maybe John and Jessica and I, maybe we don't mind, having a parachute and jumping out of the plane and trying scary new stuff. But many of the people in hospitals are librarians, they're chefs, they're service oriented, they're careful and cautious. They're not going to show up and program an agent out of the blue. So how are you training your workforce to adopt these cutting edge tools?
Great. All right, let's shift. Next topic. John, your turn. From your perspective, where are health systems dropping the ball as it relates to AI governance? And I know we had a talk yesterday offline. We're talking about what's the connection between data governance and how does it relate to AI governance? Can one happen without the other?
No, that's the simple answer. And I think I actually had a conversation with the chief medical officer recently, and he kind of actually poo-pooed the whole concept of data governance, saying, now that we have AI, it's going to take care of all of that. And I mean, he didn't exactly say that, but that's kind of the summation. And I think that a lot of the people who are making a lot of these decisions, particularly with regard to resourcing of where we're going to put our efforts, are missing the point that we need to do a lot of the basic stuff first. Even to Jessica's example of MedPearl, they put in essentially a form of AI and data governance by having the human experts curate the content. And until we actually get to a point where we can dictate and put some guardrails and define things better, we're not going to we're not going to be able to move forward with our artificial intelligence. That's kind of, if you pull the threads, that goes back to basic data governance. And I think that it's very boring, arduous, very low profile work, but it also requires a lot of time and patience. And I think a lot of organizations don't have that time and patience, and they just want to turn on the AI spigot and have it work because it's supposed to be magic. What they don't realize is that you have to do a lot of this basic foundational stuff first.
What do you guys think, Amy, Jessica, about the idea of data governance before AI governance? Do you guys agree? Is this something you guys have already been able to get past because of your data analytics teams?
I feel they're complementary. Right now we drink from a fire hose of AI. We have more than 80 models in our health system, everything from, imaging informatics to machine learning models to generative AI. There's no way, not even a governance team can barely keep up with the sort of the spreadsheet of all the AI models. And, when was the last update? How is it performing? There's so many things to think about. So, coming back to your question, I think that the data governance is separate from AI governance. AI governance has a lot to do with the people and the workflows and the safety. Should we be doing it? Should we be paying for it? Is it performing as expected? Do we have all the processes in place? And so our AI governance is mostly across the health system, all the members, nursing, risk and compliance, legal. There's so many different members on this team, a data scientist. Data governance can be predominantly an IS sort of thing, but AI governance is completely not.
Great point. Jessica, I reflect on our conversation several weeks back, and we were talking about the organization as a whole that's suffering slow decision-making or too much red tape holding up the committee. And you brought up this term, and by the way, I've used it all over downtown Palo Alto, organizational constipation. I thought that's the coolest term. How is that impacting your AI governance strategy? Is everybody on the same page, being done better?
I think that organizational risk and the risk to patients, right, is people feeding PHI into AI models. I didn't realize this, but apparently we have a gap in education sometimes about whether the AI is actually secure, and you cannot put PHI into any sort of random engine. I think that's why we have to build tools that work, like an internal protected AI that clinicians can actually use to protect against that. I think that is what really causes the multiple layers of checks and balances that are needed to protect patients, right? But I think when we get to the point where people understand, this is not, these other tools that are not approved are not secure, you cannot put patient data in them, then you have this approved suite of tools inside of the organization that work and are secure. That's the moment where you can actually move forward. But I think that is the main hypertension, right? Which is a warranted concern that we cannot have that. So in Providence, there's very clear guardrails around what tools can be used on company computers and what tools are secure and all of that. So I think we have some good foundation on that. I think what we'll have to navigate is that necessity is the mother of invention, right? So clinicians are figuring out how to solve their own problems, and we have to try to stay ahead of that in service to them so that they will have tools that work, that are compliant, that are within the ecosystem. And the other piece I think is really important is with any AI tool, the first question I would ask is does it result in greater encouragement for the people doing the work? Do the people doing the work think, oh, thank goodness, this is so much easier? The reason I ask that is because I think in the literature, one of the major things that impairs clinician adoption of any tool is the perception that it increases their risk of making a mistake. So it has to encourage and make their work easier and also be right. And once they become confident in that and understand some of the risks, to Amy's point, I think then that's when we're going to see a real acceleration.
Point. I want to shift back to Amy. I want to pull on the thread that Amy brought up earlier. Who's responsible for AI oversight within your health system? Do we have the right person or team on the bus steering AI strategy and governance?
So yeah, I think that it's important to have a chief health AI officer. And even if you don't have an assigned role, make that role part of someone else's role who's up for the game. And this should be someone who's excellent, not just at staying contemporary with the literature, but engaging people, because it's all about the people in the leadership, and we have to have difficult conversations. Jessica talked about all the different workforce components. So if you're going to have a new fall risk tool in the ICU with a camera that's watching the patient, like, how do our nursing teams feel about that? How do the ICU docs feel about that? How do patients feel about it, right? So you really need, again, a leader at your organization that's the assigned champion for this work, but you need a whole team behind it. And if you want to be super interesting and accelerating in this, I would say you build something novel to do the work. So at UC San Diego, we have the Jacobs Center for Health Innovation. We've built a health innovation input. We have biomedical informatics, health systems, School of Engineering. So who are your partners to do this work to up-level your game?
Excellent. John and Jessica, what's your take on AI oversight? Should it be led by clinical leadership, IT, legal, or somewhere else within the organization? What can we build on what Amy just brought up?
Well, at least on the clinical side of things, I'm biased, and I think I'll get agreement amongst the other two people here. But really, clinical informatics should be leading it, because we are able to bridge all of these gaps and be clinical, be operational, understand the IT. And very few people in the organization actually have that combined set of skills. And I would also say that one of the things that I think we need to really start exploring is using AI for the oversight, because it's really, really complex, and it requires a lot of dimensions of data and interacting with people and collecting all sorts of various work streams to understand whether something is working or not, or alternatively, to be able to identify very quickly without a lot of operational overhead whether something is not working properly or is in fact dangerous.
Jessica, what are your thoughts?
Yeah, I would agree with John. The only thing I would add is before we make investments, we should ask the people doing the work if they would find whatever we're trying to do helpful. Because I think you could invest probably infinite resources, but there's a big difference between actually getting something done and creating a more efficient workflow and just appearing to do something with AI. There's kind of a big gap there. So, for example, I used to work with an AI enabled tool, and it turned out if you just assumed that the hospital was full, that worked better. So we have to be, I think, very close to the work being done to understand whether the investment is actually going to make us more productive, higher value, able to deliver better care. I think, clinical informatics is really cool. And I am not an expert clinical informaticist like John, but I think you have to have someone who can bridge the gap, because the clinician would understand whether it helps them or not, but the informaticist can do the really important pieces like, is this tool producing a result with fidelity? Is the model biased? How is the model performing? Clinicians can learn that, but it's not part of our normal everyday lexicon, right?
John brought up a really good point about the idea of the AI actually monitoring the use of these technologies. So it looks like the use of AI is really multifaceted in how it can actually help solve the problem. At least that's what I heard about.
Yeah. And one other take I would take on what Jessica just said is that in addition to hearing from the clinicians and the frontline workers whether something would be useful to them, adjacent to that is understanding the technology and also some of the other operational clinical workflows and coming up with new ways that where the existing technology can be used. So for instance, I'm working with an ambient vendor, and they are working with nursing documentation. But one of the other things that I think that same technology can be used for is to extract other types of discrete data to then be repurposed in other downstream workflows and analytics. So for instance, if I am a physician talking to a patient and I have a conversation with them, and it picks up on the fact that the patient is either non-compliant with their medication or they have some other social determinant that is affecting their long-term care, you can then theoretically extract that and put that in as a discrete data element within the patient's medical record, and then use that for downstream decision support. So let's say the patient, you're able to pull out the fact that, number one, the patient is a diabetic and they live in a food desert and they eat at McDonald's every day. Well, then that could then, if you're combine all those pieces of data, you can then put that into some sort of population health framework, have some sort of case manager then arrange for, say, food delivery for that patient. And that's the sort of thing that I think that where there is a tremendous opportunity if we get out of the mindset of trying to deliver healthcare the same way that we've delivered healthcare for the past 3 to 4 decades.
Great point, John. All right, let's pivot. Jessica, I'm going to direct this to you. Getting clinicians involved in AI decision-making can be tricky. How do you engage frontline team members without overwhelming them or sidelining them?
Interesting. I would flip that. I actually think they're very engaged, at least at Providence. The frontline clinicians are the ones pushing us forward. They're the ones that send to me, hey, I found this new thing. Check it out. Can we get this through governance? What is it? I mean, they're very invested in doing it. So it's more like, how do we elevate their ideas and make sure that they don't get discouraged in the process of going through diligence around safety? For us, it's more that. But I want to go back to something that John was saying. I think it's so interesting too about patients. You know, I just think really simply about this. The value that we sell is what the patient would actually pay for, what the patient actually thinks is valuable, right? And the first article we read in medical school was something by a guy named Danny Wedding. And he talked about how if you take a big bunch of patient visits, and you observe all the characteristics of them, and then 30 days later, you ask the patient, hey, are you feeling better? The only thing with that big group that's related to whether they report feeling better 30 days later, it's not whether I did imaging, it's not whether I did tests, it's not whether I placed a referral, it's not whether I ordered medication. And John, as an ED doc, you're going to think this is real family medicine woo-woo, but the only thing related to whether they said they felt better at 30 days was whether the doctor listened closely enough to understand their perspective, the patient's perspective of the problem. So whatever we do, we have to drive that. Or like in the hospital, if you look at predictive models for survival, the most predictive thing is how many minutes the nurse was at your bedside. So we have to drive that. So looking at the things that actually produce the value and then engaging the AI to protect that and to grow that. I think that's what the business success will be based upon. Because you can do all kinds of fun, interesting, cool things with AI. But whether there's actually an action that in the end drives business value, I think that's the really interesting question.
John and Amy, do you guys want to pile on here and how you're keeping nurses and physicians engaged in the AI planning? At least when talking with Jessica, it looks like everyone is excited and can't wait to get their hands on MedPearl. But what are you experiencing from your?
Well, you got to have the tools. It's fine to bring the tools forward, but you got to have the tools that actually work. And then you also have to, and I think we touched on this a little bit before, you have to shift their mindset a little bit. So a perfect example is that I was talking to one of my other ED docs about the ambient documentation tool that we have in place. And she was a little iffy on it. And this actually touches a little bit on what Jessica just said. I said, and it's kind of prompt engineering-ish, that try this instead. She was a little bit dissatisfied with the output. As you talk to the patient, then at the end of the conversation, summarize what the patient just said as you understood it, and that then helps train the documentation tool, the ambient tool, but it also reconnects you to that patient. The patient, it's reinforced to them, hey, this doctor actually listened to and understood what I just said. And it's a very different way of doing things. And whereas before we just had the conversation, run back to our workstation and madly type in the note before we forgot it. But it's a different way, and you're leveraging the technology then to accentuate this human connection, but also understand how the technology works, and then leverage a different way of doing things to optimize the technology, both for your purposes and for the purposes of the patient.
Amy, at UCST, what are you doing to get clinicians involved? Are you doing focus groups? Are you doing roundtables, pilot programs? How do you get that feedback from the frontline individuals and then incorporating that into the overall strategy?
Yeah, well, I love this because I'm going to say engaging clinicians is show and tell, right? It's like, you know, we have a big meeting and the surgeons are there and the radiologists are there. You know, you get your phone and you run around and you say, let me show you how this works. This is so exciting. It's show and tell. They said, I heard about ambient. How does that work? Let me pull it up. Let me show you how it works. This is amazing. This really reduced the documentation burden. You create a buzz. If you don't create a buzz at an executive level, it doesn't permeate the institution. But it doesn't happen just there. It's in the hallways that we talk to our clinicians. So you walk up to someone. I walked up to a doc the other day. Awesome doc, PharmD, MD, brilliant. I said, did you try it out? They said, well, I don't know. I'm not sure how to do it. I said, don't worry about that tip sheet. Give me out your phone. They said, oh, okay. Oh, I'm not sure. Okay, let's pull up the schedule. Let's pull up this. Click, click. That's it. There it is, right there, ready to go. Show and tell. You just tell them, I'm right here. I can help you through this. This is going to help you. Tell me what you need. And CMIOs, they create a vibrancy. We create a buzz. It's fun. It's doable. This is our job, is to engage the frontline clinicians and the leaders to adopt new technology to make healthcare better.
That's because they have Amy Sitapati.
All right, let's final question here. John, I'm going to let you start off. If you were advising hospital leaders today, many on our audience, what's the one thing they should do right now to stay ahead with AI?
Data literacy. Learn how data connects with the AI and how to operationalize that in such a way that you don't get into trouble.
Who should be leading that effort?
Clinical informaticists, of course.
Okay, good. Jessica, what are your thoughts? What are parting words you'd like to make for CMIO colleagues to be successful in leading in 2025 on AI?
Take a big, deep breath and realize how important you are in the ecosystem, because you actually are the bridge between clinical care and understanding what the heck our informatics colleagues are talking about.
Are all the informatics colleagues on the same page, or are there different viewpoints on what the priority is and how to actually execute?
Oh, of course, there are different priorities, but iron sharpens iron, right? And I think we have to be fearless about feedback and about the fact that we could be wrong. And it's pretty exciting to be a beginner. I mean, AI has presented this great opportunity that literally we wake up and what we knew yesterday is not good enough. And that's pretty fun.
Great. Thank you, Jessica. Amy, what are your parting words?
Go use it today. So I think everybody should be using artificial intelligence. Define what matters to you and see what's out there, cutting edge, that can be adopted in your organization. Don't be afraid to use it, try it, and put in that AI governance. You're totally capable. You're a change agent.
That's awesome. I just will share with you guys, because it's really about you guys, not about me. I was in the ED at Stanford for 10 hours, and I had ChatGPT out because I got instructions on why I was in the ED, and I was able to use ChatGPT to able to communicate better with the doc. Now, I know docs never like that idea of Dr. Google, but I found it very informative for me as a patient of what I was experiencing and why I was at the bottom of the queue. And so I thought it was really interesting. I wonder if that's a additive thing that patients are using, things like ChatGPT, to interface with you guys as clinicians.
I'm seeing it. Definitely. And it's going to, as it infuses to the broader culture and becomes integral to how everybody actually operates their daily lives, it will become an increasing feature of how we interact with patients. And actually, that in and of itself should be the fire, the thing that lights the fire under the seat of people and clinicians who are involved with this. Because if you don't adopt the AI and do it right, you're going to get burned by the patients who are using it. And maybe they're using it inappropriately, but still they're using it, and you need to keep ahead of it.
You know, it's kind of funny. It used to be democratized in Palo Alto. You know, you have a lot of highly educated people, lots of tools. But now all of a sudden you can have the immigrant in Bakersfield, California now, who's bringing up his Obama phone and bringing up issues to have a more intelligent conversation with you as a clinician.
I mean, anything that improves the human connection between the patient and the doctor is worth doing, right? Whatever it takes. Although I will say, my son went to the ED recently and was sitting next to an elderly lady, and he hadn't been in an ED before. So he turned to her and said, "What are you in for?" And they had a very wonderful conversation. So I think to the extent that we can speak the same language with AI, that's awesome. But it'll always be about what medicine has as its foundation, right? Which is the human connection and the caring that the patient values.
Well, I think we have a wrap. Amy, Jessica, John, thanks for sharing all your insights. It's been really educational. You guys are my favorite. So for our audience members, if you have a story to tell or want to hear more about the episodes like this, head on over to beyondtheblueprint.com, and thank you for listening. Thank you for listening to Beyond the Blueprint. Together, we're exploring how thoughtful design can simplify complexity, enhance patient care, and create meaningful change. If you found value in today's episode, make sure to subscribe and leave a review in order to help us continue the conversation. Let's reimagine healthcare together on Beyond the Blueprint.